Hello everybody, this is Osama Shawki from the operating room in Cairo, Egypt, and I would love to share a very interesting case with you. We all agree that Asherman, the intertrine synechia, is the nightmare for gynecologists and the most frustrating for the patients. Prognosis is very bad, surgery is extremely difficult, as if you are working in a frozen pelvis. So Yahya, come close up and show this, a case of almost a zero cavity, and just spot it. So the strategy here is, number one is to do proper ultrasound preoperative to know the direction of the uterus. Is it anteverted or retroverted? Because here the entry of the uterine cavity is almost blind. It's not like normal case here. Yeah? In the normal case, you see the black hole of the internal os, and then you can decide to go anterior or posterior, whether the uterus AVF or RVF. But here, in this case, you don't have any clue how to go in. So preoperative ultrasound is essential to know the direction. Second advice is to use the maximum possible fluid pressure. People get panicked from fluid overload. Come on. You are just using a jet wash only to enter from the internal os. You will not sustain or maintain this pressure inside. As I always repeat, a good, talented hysteroscopic surgeon is the one who knows how to alterate, change, readjust, modify the pressure all through. It's not like laparoscopy, you put the machine to 15 and you work for 5 hours. No. So use the maximum pressure just to overcome the resistance. And then I will share with you the video to see how I could, with extreme difficulty, slide. I don't say enter. You slide, you glide, almost without vision. Here comes the question from everybody. Yahya, people ask, how could you know your direction? There is no vision. It's all in the tactile sensation. When I push, I feel a resistance. By time you get it's implanted in your hand, the resistance of the muscle different, the resistance of the cervical canal stenosis different, the resistance of other tissues. So when I feel that during the push the gliding is going in smooth, I keep on. If I feel different resistance, you change the angle. You change the angle, like exactly like the pilot while approach the runway for landing, okay? You change the angle while sustain the push, and suddenly you are inside a cavity, either the uterine cavity or the pelvic cavity. I wish you find my tips valuable for you. Once again, this is Osama Shawki from Cairo, Egypt. Thank you.
In fact, little details results in big success. So let me share with you these little details, minute tips and tricks which results in big success in surgery. While driving through the cervical canal, sometimes there is a thick viscid mucus like this, and when it covers the lens, it becomes very cloudy, and the situation will be like driving your car in the heavy rain or in a very cloudy climate, so you don't see well, and eventually you'll do an accident going forced track or a perforation. So give it time inside the cervical canal, rotating your telescope clockwise, anti-clockwise, direct the jet to the wall of the cervix to clean. And now, after having this beautiful clear view, look at the lines of the endocervical mucosa and take it as your GPS track to tell you where to go or to drive you to the internal os. But unfortunately, this is a case of a zero cavity and there is no clue for the internal os. And here come the most crucial, sensitive part. Gently push the telescope and feel the glide. Again, I say it, feel the glide. There is no black hole to guide you. There is no direction. It is very scary. So everybody asks me how you trust that you are in the perfect position or the perfect direction. It is the resistance of the tissues. You can see the gliding easily and slowly and gently while the adhesions release more. That's it. And suddenly you're inside some cavity. As I said before, it's either in the correct uterine cavity or you find yourself seeing the bowels. So what is the clue? Again, I repeat it. The clue is the feedback resistance of the tissue while you are pushing. It will take time until you have this sensation in your hand. Hysteroscopy is a very gentle, sensitive maneuver. It needs a very sensitive hands. Now, inside the cavity of the uterus, there is a big central band of adhesions. I can say almost occupying more than 50% of the volume of the uterine cavity. So let's watch together and see how to complete this procedure to full success. I do repeat again, in Asherman surgery, please always use mechanical scissors and stay away from electrocautery. The endometrium here is very poor, it's atrophic, and electrocautery might destroy and damage the very little residual endometrium that she has. Again, as I mentioned in the beginning, that during insertion, although there is no visibility, but the tactile feedback guide you that you are going into a correct direction. Here again, cutting by the scissor, you always get the feeling of the consistency, the resistance of the tissues. So this tells you are cutting into a fibrous tissue or a myometrium. Again, hysteroscopy is a tactile tissue structure surgery. Your sensation of the tissues is transmitted from the instrument, which is the scissor, to your hand. So in this case, we can appreciate how much expansion of the cavity done. Well, the guide for you to know when to stop is the landmark. You have the North Star, both tubal ostia, at the level of the fundus. Beyond that, you are cutting into the fundal myometrium. So please, it is not the purpose to convert the fundus to looks like an umbrella. No, is to finish the procedure with a fundus with two opposite tubal ostia at the same level. Okay, here I'm thinking what to do more. Cutting a little bit on the lateral wall to expand from side to side, but be careful that too much cutting with the big raw surface area might result in adhesions again. Asherman is a plastic surgery. It is not just cut here and there. You have to study the cavity well. You have to look to your landmarks. The main landmarks is both tubal ostia, internal os, and measure the cephalocodal distance and from side to side distance until you are happy with the final view. So measures to prevent readhesions again are many, like gels, membranes, IUCD. I do prefer to put a physical barrier with a sizable volume, which is the Fulis, and preferably to inflate it under vision, like this. So you can know how many mLs of saline is inflated to avoid overinflation and being painful, which patient will not tolerate, or less inflation that will slip in the next day. So inflation under vision gives you the optimum volume needed, and I leave it from 7 to 10 days, and then there is a lot of post-operative treatment after that. And after we remove it, we do another hysterography, and the patient come very happy, appreciating, with a message from the radiologist that a miracle was done, because she will have an absolutely normal cavity with a possible spill of dye through the tubal ostium. So, my dear friends, this is the story of the Asherman, and the video included is real time. Real time means this is the time of the procedure, which is not more than 6 to 7 minutes. It's not the speed of skills of the surgeon. Hysteroscopy is like that. Either you finish or not. From Cairo, Egypt, this is Osama Shawki, sending my best wishes to everybody. Please Visit me and enjoy hysteroscopy.